Hi, I'm Richard Stevens, media team lead and intern / writer for Klarity Health. I'm joined by Sheza Azim, our head of editing operations and a fellow intern. This is the first of what we hope will be a series of video discussions on health topics to accompany Klarity's online health library. Today we'll be talking about kidney injury and disease with Max Bell, who has kindly said he'd take part in our discussion. Max is a senior lecturer and senior physician in the Department of Physiology and Pharmacology at the Karolinska Institute in Stockholm, Sweden. The Karolinska has an international reputation as a centre of excellence for medical research and education. The research done by Max and his group focuses on morbidity or illness and mortality or death after major surgery and critical illness. He has several projects investigating long-term morbidity and mortality after critical illnesses, including heart injury and heart attack, acute kidney injury and stroke. At the end of the main questions on kidney disease, we'll be asking you a few questions on a non-kidney related topic just to finish off. Right. So that's the introduction done. So Max, what exactly is kidney disease? Chronic kidney disease.
Yeah, so CKD or chronic kidney disease is a complex of diseases that are characterized by a loss of renal function. And so it can range from direct damage to the kidney tissue, say after a trauma, or it could happen over time of decades due to, for instance, not super well treated diabetes mellitus.
Right.
That is well known. It can lead to a chronic kidney disease, and there's a staging process that we don't have to go into. So there's stages 1 to 5, and actually stage 3 is also split into 2. So there are several stages, and in normal circumstances, your physician will sort of track and trigger your biomarkers, your kidney functional markers, and stage you. And if you sort of trend towards getting a worse staging CKD, that may lead to what we call end-stage kidney disease or end-stage renal disease. And right. In those cases, you need dialysis or kidney support of some kind.
Okay, that's great. Sheza, your question next, I think.
Yeah, so you mentioned that diabetes mellitus also lead to kidney diseases, kidney disorders. So what are the chances of that? Does every diabetic patient has a chance of getting chronic kidney disorder? And how can a diabetic patient reduce the risk of developing CKD?
Right, so that's a great question. And so to answer that twofold question, yes, if you have diabetes mellitus, you are at higher risk of CKD and even progression to end-stage renal disease, but it can be changed by behavioral and lifestyle and medical changes. So there are numerous examples of people with a juvenile diabetes mellitus, i.e. they got it very early in their life, but they have treated their diabetes meticulously, and they have adhered to a strict blood sugar regimen. And if you do so, you can live your life normally without any risk of kidney disease. So it can be changed. So many people with diabetes, they do have a tendency to get small vessel disease, and these small vessels are important for the kidney. And they also have a tendency to develop high blood pressure, which is also detrimental for kidney function. But in treating your diabetes, you can, and having a healthy lifestyle, avoiding sugar diets, etc., you can avoid those issues. So it's very much a disease that can have different courses depending on how you live your life.
Great. I've got a question now. What are the main treatments for kidney disease?
So the best tips for managing CKD risk include managing blood sugar and blood pressure and cholesterol levels and all your blood fats, actually. And so in doing so, you can try to exercise and stay healthy. You can try to by doing so, keep your blood sugar in the normal range as much as possible. And that's usually tested by, first off, measuring your blood sugar levels, but also measuring your HbA1c, which is like a long-term biomarker for your blood sugar levels. So in doing so, you can test that, you can sort of keep tabs on if your blood sugar on a day-to-day basis actually is in a good range. And then you can try to, like I mentioned, stay in your cholesterol range, and also check your triglycerides, which is another cell in the. Also try to avoid high sodium foods, so salty foods should be avoided, and also really try to keep tabs of your medication. If you have a high blood pressure, try to keep adhere to your medical schedule to avoid high blood pressure, because all those micro insults, your blood pressure being high, or your blood sugar being out of range high, and your cholesterol being high, all those add to the risk of CKD for a diabetic patient.
If a patient already has CKD, how's CKD actually treated, Max? I know probably a lot of people know this already, but it's just.
Well, again, CKD per se, once it has happened, once your glomerular filtration rate, your function of the kidney has deteriorated, you can't easily bring that back. But you can treat it by lifestyle changes, like we said, medicines to treat high blood pressure and high blood sugar. And if you are in the range of higher CKD levels, you're progressing towards end-stage renal disease, then you need some kind of kidney replacement therapy.
Right.
That can consist of, which is most common, intermittent hemodialysis. So you need to go to a center and get your blood cleared through an artificial kidney machine.
Right.
Or you could have do a kidney transplant. You can replace one of your sick kidneys with a more healthy kidney. And overarchingly, what you do is you try to actually by machines or by replacing your kidney, you try to jack up your kidney function. So the clearance of toxins, etc., will be improved by that.
Okay, great. Okay, what does eGFR mean?
So eGFR the E stands for estimated, and the GFR stands for glomerular filtration rate. And it's a way for us to measure how well the kidneys function. And to truly measure GFR, which is called mGFR, measured GFR, it's a complex procedure where you have to inject a substance into your bloodstream and then test how it sort of goes away from your bloodstream. So you essentially test how the kidneys clear that specific substance, like iohexol or other substances. And the eGFR stands for an estimation of that by using intrinsic biomarkers that you have in your body, like creatinine or cystatin C, which are substances we all have in our body all the time that are in principle cleared by the kidney. So you can measure a creatinine level from me, from you, from whoever, and then by just looking at that creatinine level and your body weight and your age and your sex and your ethnicity, you can then estimate the glomerular filtration rate by the level of that biomarker. It's not perfect, but it works well enough.
Great. Okay, what are the differences between acute kidney injury and CKD, and can one lead to the other?
Yeah, that has been one of my research interests, and sort of surprisingly enough, AKI, or acute kidney injury, is again a complex set of diseases sort of lumped into one. Acute kidney injury can stem from a severe bloodstream infection, a sepsis. That's one of the most common cases. You get a severe bloodstream infection, your organs shut down, and you need critical care. And one of the organs shutting down is the kidney, and that's called AKI, acute kidney injury. But AKI can also be caused by a long surgical operation, for instance, a CABG operation, a cardiac operation, where the time on the cardiac machine is a sort of an inflammatory insult that we know also causes acute kidney injury. And then there are also other reasons like extreme hypertension, very low blood pressure, for instance, during a trauma where the patient has been bleeding a lot for a long time and the blood pressure was like super low for a long time, that can also cause kidney injury. And yes, non-surprisingly, AKI can lead to CKD and or the progression of already prevalent CKD. And weirdly enough, it was debated for a long time, but it has now been proven in multiple studies that yes, acute kidney injury, which is like a really short-term lowering of the GFR, glomerular filtration, actually cause sustained damage that can progress to CKD, or like I said, have the CKD stage go from like stage 1, which is light CKD, to like stage 2 or 3, increased CKD.
Okay, that's great. You broke up a little bit on that, but I think we'll be fine. Sheza, this is one of your questions again.
So I was wondering if are there some painkillers or statins that can make the kidney disease worsen?
Yeah, there are not dangerous, but so some painkillers, including NSAIDs, non-steroidal anti-inflammatory drugs, which is like a really normal painkiller, your normal Tylenol, etc. In high doses, those can cause kidney damage. So for me as a physician in the ICU, I usually avoid those substances. I have patients with pain, but I avoid those substances and instead rely on other analgesics. And again, for elderly people, for instance, with say a high blood pressure and or a diabetes, it's prudent to avoid high doses of those medications. So there are those associations, and I think you also mentioned statins. So statins are medicines that are given to patients to lower their cholesterol. They bind cholesterol in your gastrointestinal tract, so you'll have a low cholesterol in your body. And those are also known to be affected by kidney disease. So patients with CKD may have to adjust their statin.
Okay, that's great. Here's a sort of slightly a left field question. Is ammonia breath a symptom of CKD?
Yeah. I've been a physician for a long time, over 20 years, but I've actually never counted this. But so if your kidneys function decline, you will accumulate a lot of toxins in your bloodstreams, including one of the toxins that we usually measure, which is called urea. And urea is a way for the body to remove excess ammonium. So in CKD patients, or patients with untreated CKD, I should say, ammonia breath can be a sort of a bad sign that their urea levels, their blood urea levels are high. And so if, for instance, a general care practitioner would meet a patient with ammonia breath, it would be wise for them to contact nephrology specialists to have that investigated. So it's a good question.
We've done quite a bit about kidney stones at Klarity.
Yeah.
And one of the topics that came up, you probably remember this from when I first contacted you.
I do remember.
Is whether or not green tea is effective against kidney stones.
I had to read it up. And I mean, it's kidney stones is, I mean, it's said to be one of the most, and as a physician, as an intensive care physician, I seldom see this anymore. But when I did my general practice, of course, I've seen patients with kidney stones. It's extremely painful. So anything that can avoid kidney stones for a patient who've had it would be something you hold on to. And so a component of green tea called EGCG, I had to read up on this, and it might help to protect against kidney stones because the crystals in the kidney stones are made of oxalate, and this substance in green tea actually do not have. It differs from black tea in the sense that black tea can increase your oxalate levels, whereas green tea will not do that. So in that sense, it may protect you against kidney stones.
Excellent. Is kidney disease hereditary?
Well, to To a certain extent, yes. If you have, so some kidney diseases or some types of kidney diseases have a strong hereditary factor, and so does diabetes, by the way. So if you have patients whose parents have ADPKD, which stands for autosomal dominant polycystic kidney disease, the risk of getting kidney disease from into their offspring is higher. So that is hereditary. And diabetes type 1 is to some extent hereditary, and that in turn also increases risk of CKD. So yes, for some types of kidney disease.
That's great. Can we just go through the stages of kidney disease one more time? The stages of CKD, just as in as simple language as possible, really.
Yeah. So first off, the CKD staging is meant for your physician to be able to sort of track where you are in your progression in this slow deterioration of your kidney function. That's the point. And usually they take advantage of the fact that we can use estimated GFR to get a grasp of your glomerular filtration rate, the way your kidney functions. And so by looking at your glomerular filtration rate, you can be staged into very mild kidney disease, just a slight lower function, and very severe kidney disease where your GFR is very low and you will probably have a high risk of accumulating a lot of toxic substances. You're on the verge of needing replacement therapy. So I don't know if you want to go through it, but stage 1 is like you're normal, you have a GFR over 90, and stage 2 is like then 89 to 60, and then stage 3 is like 59 to 45, and so on. So it's essentially a measurement of your function, and that gets staged from, everything is well to you're really, really close now to getting the need of end-stage renal disease therapy, which is some sort of kidney replacement therapy, either dialysis or new kidney.
Great, thank you. I've got an open question here for you. Is there anything you'd like to discuss about your research at the moment? What you're doing? What's exciting you at the moment in your research?
Well, I always like to discuss my research, but it's no, but it's so. I would say this: the need for investigations into long-term organ damage after critical illness or after major surgery is still a field where too little has been done. So both in terms of the perioperative process, i.e. you're getting operated on and then you hopefully wake up after anesthesia, that's sort of been focused on avoiding pain, which is really great, and also avoiding looking at short-term mortality, which is also great. And the same goes for intensive care. It's usually measured, your quality of intensive care is usually measured by measuring like 30-day post-ICU mortality, which is great to know. But we need to sort of increase our ambitions and look at long-term morbidity. So that's my message basically from my research. We want patients to not only survive the critical illness, but survive with well-functioning organs. And we would like the same for the perioperative process. So it's a lot of fun. It's an open field, and there is a growing field of research into that. How can we avoid myocardial damage, heart damage, and kidney damage after major surgery or a stroke? Because nobody wants to undergo a knee surgery and replace a non-functioning knee and then wake up with a stroke. That would be a bummer, right? So we need to improve the perioperative and intensive care process to avoid those morbidity. They won't be catched by looking at mortality, but you could catch them by looking at the organ function. That's it.
That's great. That sounds really interesting. I used to be in medical research myself. I was into diabetes genomics, and I miss it sometimes. No, so I'd like to hear about other people's experiences vicariously.
Right. No, writing papers is fun. It is.
Yeah.
You had some questions about the connection between
COVID.
COVID and
AKI.
Yeah. So one of my PhD students looked at the risk of AKI in association with critical illness and COVID-19. So we need to make something clear. There hasn't been we don't know if mild COVID, like COVID that is not causing hospitalization, we don't really know how that might impact your renal function long-term.
Sure.
There will be studies on that, I'm sure. We need some time to see if an instance of like mild COVID, non-hospitalization COVID, will lead to that type of organ damage. What we do know is the critically ill patients that were treated with, invasive ventilation in the critical care units and had COVID, they had a risk of AKI much like regular patients with bloodstream infections like sepsis. So that has been proven. So severe COVID leading to critical illness and the need of intensive care unit therapy, they had a high risk of AKI. I'd say quite a bit higher than the normal ICU patient.
Right.
And then I know you had a question regarding statins and severity of COVID-19.
Yeah, sure. Because I think a lot of people are worried about every drug now. I think the hysteria over vaccines has particularly heightened people's suspicion of medicine.
Sure, and so in a way that's understandable. With regard to statins, I was a co-author, not the main author, but I was a co-author in a Swedish at the whole Stockholm region, and we had very high resolution data on people on statins and all other medications, and people on not statins, but every other medication. We had essentially high resolution data on all the Stockholm inhabitants. And we also, of course, knew if they got COVID or not. And what we could see, to my surprise, actually, was that statins actually lowered risk of dying from COVID-19.
Wow, really?
Statins were protective in the sense that statins are, in general, an anti-inflammatory drug. So it's not super surprising. I've seen studies on statins lowering risk of severe trauma because there's an inflammatory component of trauma, and statins also lowering risk of dying from sepsis. So the anti-inflammatory property of statins seemed to be protective if people got infected by COVID-19. So that was weird, but again, it's not data strong enough to suggest that we should start dispensing statins to everybody if we would get another SARS-like pandemic. We don't really have that sort of interventional data, but there was a clear association with low mortality for statin takers.
I think a lot of people would kill for that data set, Max.
I'm sure they would, yeah. I think they would.
Yeah, that sounds terrific.
It is a cool data set. It's super high resolution.
Is it longitudinal or is it cross-sectional?
Actually, you could say that it's both. It's an ongoing online data tracker actually developed to track influenza vaccines in Stockholm, and it's been ongoing for years and years. And so, in order to track the quality and the effectiveness of influenza vaccines that are developed yearly, they have high resolution data from all the Swedish quality registers, including medications, diagnosis, etc., hospitalization, death, whatever. And so they just changed the tracking algorithm to include COVID or not COVID instead of influenza vaccine or not influenza vaccine. So it's a longitudinal data set.
Great. What exactly is long COVID? I know this is probably a question you've been asked before.
Yeah, it is a question I've been asked before, and it's a tough question to answer because there's not one singular answer, I'd say. So the latest research to really dig into the question, I think long COVID is things simultaneously, but I mean it's characterized by prevalence of symptoms like shortness of breath, extreme fatigue, persistent high heart rate, or the fact that very small movements will cause a high heart rate. Sometimes ongoing fever that comes and goes. Dizziness, again associated, I guess, with the heart rate, and sometimes the loss of blood pressure or low blood pressure. And then there are some instances of like a joint pain or generalized pain, and itching and nausea. So it's like one could, if you zoom out, one can understand how a physician presented with this array of symptoms would sort of retort to the fact and say, like, well, this is too vague. This is a lot of everything. But it's quite well characterized. The SARS-2 COVID-19 pandemic hit so many patients worldwide and led to the fact that we do have long COVID data that it's pretty strong, and it has these symptoms associated with it. Some of them also report the sensation of loss of taste and smell. That's very common during the acute phase of the infection, but they sort of have persistent loss of those senses. And again, so exactly how we define long COVID, when after the first infection we sort of call it long COVID, that's debated. And I would like to stress the fact that we don't really know yet if it's specifically the SARS-CoV-2 virus that is, the SARS-CoV-2 virus is the culprit of long COVID. But if we would have had another viral pandemic, like hypothetically a very severe or harsh influenza epidemic, we might have seen then long influenza. The fact that so many people in the world was afflicted by this disease will, I think, by sheer numbers, lead to some patients having these long-term post-viral symptoms, because they're not unique. Some patients with other viral infections like influenza or other viruses, similar long-term symptoms may be due to some sort of dysregulation of the immune system caused by the primary virus.
Great. Last COVID question, I promise.
Sure.
How does COVID-19 affect your heart health?
There's pretty solid data from a couple of countries looking at both patients with severe instances of COVID, i.e., again, needing hospitalization and sometimes critical care, but also patients with a light COVID. And it seems to be pretty strong data linking even it's much worse if you had a severe COVID infection leading to critical illness. And that in those patients, a worsening cardiac function, and I'm speaking generally here by choice, a worsening cardiac function is well known.
Right.
But it's also been shown that even some people with light COVID, just having a positive test and then feeling ill a couple of days and then nothing more, actually have signs of affected myocardial function. And how that will play out in the future with regards to long-term morbidity and mortality among the elderly of the world, or even younger people, is not known yet.
No. That's great. Okay, that's it for COVID now. I'm done.
All right.
Right. Here's a question that relates to one of the articles we've published already. That the heart is described as a double pump widely.
Yeah. Yeah.
What does that mean precisely?
Well, again, I'm not a cardiologist, but I'm a critical care physician. So we deal a whole lot of our attention goes to the heart and the heart's function, i.e., maintaining blood pressure and pumping blood and nutrients all around your body, which is what the heart does. And yes, it's a complex pump. It has two two sides, the left and right side. It has 4 chambers. So it has 2 atria, the right and left atria, and so accepting blood from the body. And then it has 2 corresponding ventricles, and they pump blood out. And the heart beats sort of in a double cycle. So the blood comes into the right side of the heart and it pumps it out to the lung circulation, then it comes back from the lung circulation, well oxygenated, then into the left side of the heart, which pumps it out into the body. So, and that synchronization between the right and the left atria and ventricles, they're important to optimize your cardiac output and your cardiac function. And sometimes that gets dysregulated if you have a atrial flutter or other cardiac diseases. And then the sync between the right and the left heart gets sort of out of whack, and your cardiac function will decline. So you won't have the same excellent cardiac output, because it's a very well-functioning pump. But if those 2 parts of the heart gets dysregulated, the cardiac output goes down, and you will have a lower blood pressure, and you might even it might cause cardiac failure and other diseases. So patients with those diseases are usually treated in order to we try as physicians to rectify that dysregulation and get it back to sync. There are a couple of ways to do that medically.
Okay, that's great. Last question, and a slightly different tack. What impact can diabetes mellitus have on sexual health for men and women?
Yeah, so it goes to, so some of the problems with the long-term effects of diabetes, the long-term detrimental effects of not perfectly treated diabetes, they all the small vessels getting blood to other organs and to the larger vessels. Even our vessels have vessels to keep them lubricated. And so one of the theories, the prevailing theory, is that the fact that the kidneys are at risk, like we said, untreated diabetes can lead to kidney disease, and the fact that your eyesight can be affected with untreated diabetes mellitus also has to do with small vessels in your eyes, and the fact that the libido can be changed, both with men getting erectile dysfunction, with women experiencing less lively libido, lowering sexual appetite, whatever. That can also be explained by the fact that we have small microvessels that are important for those organs. So I'd say that the overarching phenomena that we are seeing with terms of loss of kidney function, loss of libido, potential loss of eyesight has to do with microvessels that are not functioning well if your blood sugar is out of range. And also the fact that these small microvessels actually help your nerves stay healthy. And if the nerves deteriorate, then that can affect your erectile function and also the touch and feel. Sometimes patients with untreated diabetes complain of not feeling their feet. And that also has to do with nerve tissue damage secondary to microvessel damage. So it is really important for patients with high blood sugar to keep it in check.
Yeah.